Hey guys, nice to see you again. How about the last session 27 about the tuberculosis? Was it interesting? I hope so. Let's go into active pulmonary tuberculosis, 2 of the 3. Let's enjoy the chest radiographs with Dr. Y. I'm Dr. Y, chest radiologist, medical professor in South Korea. Today's session will be about the many findings of the real cases of active tuberculosis, the most important session of the tuberculosis. Let's go. Let's start from the definition of active tuberculosis. Active is a diseased condition caused by the bacteria named MTB, Mycobacterium tuberculosis. It is a disease, not the infection. Radiologic findings of active tuberculosis. Actually, this slide is the most important slide of the tuberculosis of 3 sessions. It was written by Dr. Nachapan et al., Pulmonary Tuberculosis, Role of the Radiology in Diagnosis and Management, Radiographics, year 2017. I repeat this slide again from last session. Number 1 is cavity formation. This is active lesion. B, consolidation. C, tree in bud pattern. Also, the name is centrilobular nodules. D, miliary nodules. E, lymphadenopathy. F, pleural effusion. If we see these findings in the chest radiographs or CT, we can say, yes, this is an active tuberculosis. This patient is ill. He needs treatment. Let's do it again. Cavity, consolidation, tree in bud pattern, miliary nodules, lymphadenopathy, pleural effusion. Radiologic findings of inactive tuberculosis. A, peribronchial fibrosis. B, well-defined nodules. C, traction bronchiectasis. D, upper lung volume loss. E, calcified granulomas or calcified lymph nodes. It is a little more complicated. I, Dr. Y, would say simply, inactive findings of tuberculosis are without active findings. I would say simply, without active findings usually means inactive findings. This is a young man's chest radiograph. Right hilar area is looking abnormal. Left side is normal. Left pulmonary artery is looking normal. But right pulmonary artery does not looking normal. So this means there is a pathology overlapped or attached with the right pulmonary hilum, right descending pulmonary artery. Yes, let's go to the actual CT, lung window setting. Yes, there is a cavity here, right lower lobe superior segment, and thick consolidation and tree in bud. With also, this is pleural effusion. Attached with the right pulmonary vessel, right hilum. Let's look at this middle-aged man's film. Left side film is before treatment in active stage, and right side film is several years after treatment in active stage. Let's look at the right upper lobe. Something abnormal. Let's look at the normal left upper lobe. Left upper lobe is clean with black density with fine small pulmonary vessels. But look at these right upper lobe. There are many densities. We used to say mottled or ill-defined nodules. How about the several years after treatment? The densities are not crowded anymore. Let's look closely again. Crowded here. This is normal area. Nothing here. But here, there are many densities crowded with something. Small nodules, fuzzy margin, ill-defined nodules, we sometimes express as mottled, M-O-T-T-L-E-D, mottled densities here. How about after treatment, after several years? Not crowded anymore. No more ill-defined nodules, no more mottled density. Only fine, streaky, well-defined small nodules. This is inactive, this is active. Let's confirm on the axial lung window setting CTs. What happened on the chest radiograph here? Yes, the branching density is tangential view of, we used to say, tree in bud, TIB pattern, bronchial lesion, bronchial cageation, necrosis material, and this is ill-defined nodule. This is enhanced view of branching tree in bud pattern, same pathology. We call this centrilobular nodule. We call this tree in bud pattern, but it's same lesions. Look at the normal area here. Yes, nothing special. Look at the normal area here. Only fine, linear, small pulmonary vessels. But these pathologic area shows many things. That means this is diseased active tuberculosis findings. Let's find out again in another patient because these findings are the most important findings of active tuberculosis. Left upper lobe lesion here. How about right upper lobe? Yes, it's clear. Something crowded with ill-defined nodules, mottled nodules. These densities shouldn't be here in normal person. How about these findings several years after? Yes, not so much crowded than before, and the nodules margins are relatively clear, fine, and densities are smaller than before. Yes, this is healed TB, inactive TB. This is active TB. This is the magnified view. Let's enjoy again. Enjoy. Please enjoy yourself. Enjoy yourself the mottled, centrilobular nodules, tree in bud pattern here. Yes, it has changed after therapy, treatment, improved and get stable again. This is another patient's left upper lobe lesion. How about right upper lobe? Normal. Now I'm confident that all of you are the professional of tree in bud pattern, active tuberculosis findings. Right? You know everything. You imagine everything here, and let's confirm with CT, axial lung window CT. This is tangential view of branching pattern in the bronchial, called tree in bud. This is normal. This is normal. Centrilobular, ill-defined nodules, tree in bud. Same findings on emphasis view or tangential view in bronchial lesion, tree in bud pattern, centrilobular nodules. Let's go to the miliary nodules, miliary micronodules of random distribution. Do you see something here? Something here? many tiny nodules all around the lung. And do you see lymph node here? Right paratracheal stripe obliteration and more density in AP window. So this is mediastinal, a little widening, lymphadenopathy. Let's see in the axial lung window setting CT. Fissural micronodules, subpleural nodules, parenchymal, many innumerable nodules. This is a random distribution of micronodules. Hematogenous miliary nodule, less than 4 mm, relatively uniform in size. This is miliary micronodules, or simply miliary nodules of random distribution. What happened after treatment? This slide is after treatment. We don't see many nodules here, almost disappeared. How about the right azygos lymph node area? Bulging nodule here, that lymph node has decreased. How about AP window? Less density with a shallow AP window. From here to here. Improved lymphadenopathy, improved miliary nodules. Let's go to another case of the same findings. And this is after treatment. Normal looking. Yes, normal looking. How about her original face? Paratracheal obliteration, AP window lymph node, hilar enlargement, interlobar lymph node enlargement, and also in the peripheral lung field, we see many innumerable micronodules, miliary nodules, all gone after treatment like this. Let's find out in the CT. Let's confirm with this axial lung window setting CT. These are for our AP window lymph node enlargement. And there are numerous micronodules, relatively uniform in size, less than 4 mm. There is no single area of normal area. Almost all areas are filled with micronodules of random distribution. This is miliary tuberculosis. No single area of normal area. Yes. Lymphadenopathy with miliary micronodules. This is active tuberculosis findings. What happened to the mediastinal lymph node of these patients? Yes, many lymph nodes of central low density. Central low density suggesting cageation necrosis with rim enhancement of granulation tissue. Many round lymph node enlargement with central low density with cageation necrosis and rim enhancement of granulation tissue everywhere. Paratracheal, subcarinal, AP window, interlobar and hilar lymphadenopathy of tuberculosis. Let's go to the tuberculous pleurisy, lentiform, pleural effusion, homogeneous density here on the lateral based, pleural based. Yes. In left upper lobe, there are inactive tuberculosis findings here. Fissure thickening. This is tuberculous pleurisy. We confirmed tuberculous pleural effusion of lentiform or crescent-shaped pleural effusion here in non-contrast enhanced axial CT. After drainage, The pleural fluid has gone. Let's look at this patient before, several years before, and today. What's the difference? First, let's go to the right upper lobe. This is old film with poor resolution, but at least there is no change. This is today's film of good quality. No change of fibrosis and calcified regions, but so we can say right upper lobe lesion is stable TB lesion. And how about left upper lobe? This was stable. This used to be stable, but today there are too many things in left upper lobe. Too much crowded than before. Pleura is thickened, mottled, ill-defined nodules, very much crowded. That means something new has happened here. That is tuberculosis activated. So this is active tuberculosis. How about these magnified views from this to this status? Yes, this is all tree-in-bud pattern of bronchial lesions. We know very well about these findings. Yes, this is active tuberculosis. Tuberculosis is come back here again. But we do not guarantee whether this is reinfection or reactivated. Just we know that the disease is come back. He is active again in left upper lobe. Inactive findings does not guarantee no reactivation nor reinfection. It can be anytime or sometime can be reactivated or reinfected according to the patient's immune status. 5% of active tuberculosis patients manifest only with nodule, named as granuloma. Only finding is this 1 centimeter granuloma nodule, nothing else on whole other lung. Nothing else in whole other lung. No lymphadenopathy, no micronodules, no tree-in-bud pattern. Only this nodule on Xray on coronal image here. This was confirmed as tuberculosis. Nodule has always a problem for us in interpreting because we always think about the cancer. Nodule can be cancer, lung cancer, so it is not easy to differentiate with a single nodule to granuloma or lung cancer. How about this young woman's chest radiograph? Do you see the trachea here and right main bronchus, bronchus intermedius, right upper lobe? Yes, sure, we can. But how about left main bronchus? Do you see well as other normal films? No, not clear here. It is somewhat narrowed, irregularly narrowed. Also with tuberculosis findings in left upper lobe. Left main bronchus is not looking good. What happened? Let's look at the axial CT. Right main bronchus is okay, but left main bronchus is narrowed from the beginning, from the carina. Yes, this is coronal image. Left main bronchus is severely damaged with a thickened wall and narrowed and deformed. This is bronchial tuberculosis. When we see this kind of findings, we usually simply say tuberculosis destroyed lung. What is destroyed lung? Look at this. Trachea is shifted to the left. Heart is hidden in the collapsed left lower lung, not in the center. And right side lung is herniated to the left. and left diaphragm is hidden, and left abdominal contents is elevated. Small left hemithorax with hypertrophied ribs with smaller intercostal spaces. Heart is hidden here in the collapsed left lung. On lateral film, the lung is herniated in anterior side. This is what we used to say commonly, just say destroyed lung of tuberculosis. Let's look at the contrast enhanced CT. Left upper lung zone is necrotized lung tissue with pleural thickening, and there are many hypertrophied systemic pulmonary bronchial arteries, systemic arteries, easy to bleed, easy for hemoptysis or blood-tinged sputum. And ribs are hypertrophied and intercostal space narrowed. And in axial CT of lung window setting, we see anterior and posterior herniation of the right lung to the left side, and heart is almost all in left side, and left chest cage is so small than right side. This is tuberculous destroyed lung. We are also familiar with the name Mycetoma or fungus spore, like this spongiform lesion in the destroyed lung of tuberculosis, large cavity. This one. Air is surrounding this area. In axial contrast to CT, we see non-enhancing spongiform lesion here, and non-dependent portion is surrounded with air according to the gravity. This is monod sign of mycetoma. We sometimes mistakenly use the term air crescent sign. That is not correct for here. That is for angioinvasive aspergillosis. Another case of a TB-destroyed lung showing mycetoma in the upper lobe and left side, and air fluid level here. Air fluid level means air connection with somewhere, usually from bronchus, that is bronchopleural fistula. In axial CT, we see the basal pleural thickening with calcification and parietal pleural thickening with calcification with air fluid level here, usually with bronchus, pleural fistula, BP fistula. But sometimes this can extend, invade to the chest wall and became empyema necessitatis, or even further to the skin becomes cutaneous pleural fistula. It is usually happened in tuberculous destroyed lung. This patient shows the tuberculous destroyed lung also in the left side. Many more cases often occur on the left side than right side. This patient shows active tuberculous lesions on the right side. Active tuberculosis has happened after long-standing destroyed lung of the left side. All cavities, twin-bed cavity, twin-bed consolidation cavity. Have you ever heard the name galaxy sign? Actually, it was coined at first by Japanese doctors on CT as sarcoid galaxy sign, which means in sarcoidosis on CT. The coalescence of granulomas in the center makes a nodule looking, and the surrounding small daughter nodules of granulomas are just looking like galaxy in the universe. But after that, many other doctors continuously found the same findings on the tuberculosis, silicosis, even in progressive massive fibrosis. How about these findings? Yes, how about these findings in coronal long window setting? Not just looking galaxy, but the scattered stars crowding here. It is named as cluster sign, cluster of granulomas. In sarcoidosis, they were granulomas, but in tuberculosis, it can be granulomas, also can be tree-invert pattern nodules. How about the same patient's Xray long window setting CT? This one looks like galaxy, central nodule with scattered daughter nodules, galaxy, but the below one is looking like something like cluster sign. This is 2.5 millimeter in thickness with a fuzzy margin, but with 1.25 millimeter thickness image, the margins are clear. How about another case of galaxy sign? Look closely. This one is like this. This is central nodule of galaxy with scattered stars around. Galaxy sign, or simply it can be crowded stars, cluster sign. This coronal image shows central emptiness with surrounding stars. This is also called reversed halo, or galaxy sign, cluster sign, reversed halo sign. In tuberculosis, it is different with sarcoidosis. As I said before, sarcoidosis are all granulomatous nodules, but in tuberculosis, it can be caseation granulomas or tree-invert patterns mixed. What do we see with this patient? Yes, right upper lobe tuberculous lesion, active mottled tree-invert pattern nodules here, active TB lesion with a moderate amount of pleural effusion, diffuse homogeneous density here of pleural effusion. Yes, this is TB. Have you ever heard the name paradoxic reaction? That is paradoxic. In clinically, and the general findings of radiology are getting better and improved, but some special points, usually lymphadenopathy or like this patient, a pleural lesion, pleural empyema of one of the pleural empyema is getting worse on image, getting worse of lymphadenopathy on image only. In this case, the general conditions and findings are getting better, so please do not stop medicine. Just go on medicine of treatment of tuberculosis. Then he will or she will get better soon. This is paradoxic reaction. This was confirmed after biopsy as a tuberculous lesion. Now we are watching extensive active tuberculosis findings of this patient everywhere. Every finding is active tuberculosis findings with one more thing. This is spontaneous pneumothorax. Tuberculosis is one of the lesions which makes spontaneous pneumothorax. Okay. How do you feel now about the active tuberculosis? Was it interesting? Was it helpful? Now I'm closing the active tuberculosis. I salute you for your every effort for starting active tuberculosis. Let's meet stable inactive tuberculosis radiographs on session 29. Like, subscribe will be a big support to Dr. Y. Thank you very much and have a good day. You did Very, very good job.